Okay, today I'm actually explaining like how you should approach these recalls. Yeah, I'm doing good, doctor. Yeah, so today I'm explaining, today I'm explaining how you should approach recalls properly because I know most of you, like most of doctors, just mean recalls. They are doing recalls mean just read the question, mark the answer. Okay, that's all. That is not the way of doing recalls. I'm telling, like not in the during exam week. Exam week also it's not like that. I'm explaining like how you should use these recalls as a better revision for your future exams. This example, if you're doing exam in June, you should be at least cover past 6 months. At least 6 months should be covered from the recalls. That mean the covering recalls mean not only just read the question, okay, this is the answer, not like that. You have to understand the what is the topic. As example, if you see a recall question, first thing you have to make a note. So when you are doing some monthly recalls, just I'm giving some special points. Okay, just take a pen and paper, or you can make a document, whatever easy for you. You have to make as example, okay, you are doing the may recalls, write down the topic as may recalls. Then you can categorize it into surgery, medicine, gyn and ops, then psychiatry or ethics, like that, ethics or stat, like that. Then you can write down. Okay, when you see the first may recall, you have to write as example. If you see a spontaneous pneumothorax question, so you can write down under the topic, right? Spontaneous pneumothorax question. Then, as example, if you see a questions like CTG question. So you can write down the padhyas, like a small detail like padhyas declarations. As example, CTG declaration from under right? Ops topic. That is how you should do the recall. Then at the end of the your recalls, then you have a list of topics. So each month you should have this list of topics. Because from my other recall sessions, the doctors I'm always advising them to do that. And like in the previously past doctors also was with me. They everyone had this topic list. Okay, because then before your exam week, you have the topic list, and you can consider how many topics are repeating each month. Then you have a final topic list of 6 months, right? Then you can quickly just mark it. Okay, I know this topic. I know this topic. Like that. Then you will feel more confident before your exam week, right? But don't chase new things for exam week. I'm just telling for the doctors who are preparing for your like future exams. Okay, this is the way you should follow the recall. So what you should do, once you are doing the recalls, you need to write down the topic exactly. That is the way. Okay, then you have the topic list. If you can, like I think most of doctors who has that topics, you can ask from in the group, or like you can ask. Actually, they will help if someone is having that topic list. They can share it with you, because I know most of doctors have no idea. Then the other thing, okay, that is for the topic list, because at the end of the day, you need those topics. Then only you can get idea about how these topics are repeating. Then you can understand a pattern, right? Okay, the second thing, if you see a question, okay, you know the topic. So when you're doing the recalls before your exams, I'm just like a revision thing. You need to cover the topic. As example, if you get a spontaneous pneumothorax question, so what you need to understand, you need to go and check like what is it, then like how you should. As example, if you get a spontaneous pneumothorax, you can just cover whole pneumothorax, right? It's not like a no harm if you're covered like that. Then you can go with the pneumothorax. Then you can see the classification of pneumothorax, how you are classify these pneumothorax. Then you can take like how primary spontaneous pneumothorax is treated. Because in the TG, you have the proper guideline, proper flow chart. Because in May exam, they have asked from that exact exact chart. 1 point like observe 4 hours part. Okay, that's how you should do in your mind. All these flow charts and everything should be there. Okay, think like this. You are doing exam in June, and you are doing. recalls in February. Okay, you find this spontaneous pneumothorax question. Then again, you find it in example. Okay, in April. Now you remember, right? Oh, I have done this previously. Okay, then you have to just go through that part and that file or whatever you have the note. Then you just need to read it. That's all. Okay, in the second time you touch it, you just need to just read it because you already studied right with the you have taken more time and you already studied it, right? Then you feel confident. Then you can understand, oh, that day they asked from the treatment and today they ask from the to diagnose it like that because they are not asking the same question. That is how they should change. So you should know if you, as example, if you get a topic like as a ADHD, okay? So in the ADHD, the what are the things they can ask? They can ask what is it, the diagnostic criteria. So what is the first line treatment? It's a non-pharmacological. So what is the second line treatment? Second line is pharmacological. Then the other point before starting these stimulant, what you should do. Those are the questions they can ask. Then they can ask what are the first line pharmacological therapy. We all know stimulant. Then what are the second line therapy? So if they can, it's associated with the Tourette syndrome, how you should read. Those are the special points in your note or in your like whatever you are studying, you should have those kind of list, right? Because then only you understand. If you see the topic in the exam, because it will easy, because then you don't need to like even buy those expensive recall classes if you have all the things. But in the exam weeks like a very stress things, you should like most of doctors need some guidance because in our own it's very hard to deal with it. But if you have those note as example ADHD question, you got it in the day one, so you will read those special point like what are the things they can ask, then you already know, then you have no stress. That is the power of doing recalls, right? You will touch, you will cover these topics before your exam be. That is the main thing, right? Okay, I'm not taking too much time, so please do that. You will be very confident. Like you can listen the doctors who did exam in March. I have shared that video only. How they prepared. They were especially explained about the how recall helped them to build up their confidence level. Okay, because in every month there are new topics, so we can't prevent that because that is the AMC, right? But if you know the like topics like more than 80% from our previous recalls, you will be more confident during your exam as like you feel, oh, I have done this question even in my last month. So you feel that is a confident level you need. Then your stress level reduce and you can do it better. Okay, so today I'm discussing about some surgery topics and some very important topics from the past recalls. I chose topics from um, February day 4 and March day 2. Okay, I'll explain. So yes, let me share my screen. Okay, I have made a special simple file. You all can see. 1 minute. Okay. Okay, so first I'm going to explain some theories from the February. Okay, here we got a question like a patient present with melena for 2 days. The rectal exam was melena. Colonoscopy and endoscopy were normal. Received 2 packed blood next day. So what you should do? So what do you think, doctors, in this question? First, you can answer me. Yeah, doctor, you can ask in our main group. I'm sure someone will help you because most of doctors who are with me in my paid recall revision classes, I'm already like advising them to do this big topic list. Someone will help you. Just ask in the group. So, what is the answer? What do you think? So, what is the theory that we should use here? Okay. So, tell me what is the theory we are using? So, what is the theory we are using here? Okay, so tell me, okay, if you see this kind of question, I know you can say it's a capsule endoscopy. So, what is the theory behind it? What is the theory? Because you need to have some clear points. No, that is not the point, doctor. Okay. I'll explain it from some emergency questions. Okay. So read this thing. This is from my February call file. Okay, February call file. So I'll explain here. Okay, we'll discuss this question. 67-year-old, because the only two things you need to differentiate, are we going to CT or angiography or capsule endoscopy? You need to understand what are the indications, right? Okay, here 67-year-old man present to the emergency department with 4-day history of passing dark and sticky stool. He has no significant medical history and take no regular medications. On examination, he appears unwell. Pulse rate is 100, BP 118 by 78, and the respiratory rate is 18. SpO2 98% and the temperature 37.2. The examination of chest and abdomen is unremarkable. The rectal examination, there's a soft 1 minute, sorry. There is a soft stool, heavily stained with dark blood. The hemoglobin 110, and the endoscopy and colonoscopy with adequate view do not identify the source of the problem. The hemoglobin falls to 80, but he remains hemodynamically stable. So, which one of the following most appropriate next investigation? So, why they have gone with here CT angiography? Some, can anyone tell me why? Why not capsule endoscopy here? So can anyone tell me why? Because these are the questions they are asking in the exam, right? Because of that, you need to have some clear points about like how to differentiate these two things. So tell me why here. Okay. Why you are telling he is unstable? Blood pressure is 180 by 78. Is unstable? Not yet. Yes, what is the important point you should consider at the moment? His hemoglobin level is dropping right here. His hemoglobin 110, right? Then it fall to 80. That means there's somewhere there's an ongoing or active bleeding at the moment, right? But he is stable, right? He's stable, right? Yes. So that is the point you need to catch, right? Because like in the previous when I was asking, you was like, okay, if the unstable, go with CT angio. If it is stable, go with capsule. That is not the way of proper theory, right? That is not the proper theory. So how you should consider? Hemoglobin level falls to 80 from 110. That means there's an active ongoing bleeding. So let's see. And here they have mentioned he patient is hemodynamically stable, right? Patient stable, okay. So patient present with melena, dark sticky stool, and significant drop in hemoglobin, indicating ongoing GI bleeding. The normal upper endoscopy and colonoscopy suggest that the bleeding source is likely in the small bowel, making these cases of obscure GI bleeding, right? We don't know what is the it's an unknown source, right? So here CT angiography is the most appropriate next investigation in this scenario. It is rapid, non-invasive technique that can detect active bleeding rates as low as zero point 0.3 milliliters per minute, making it highly sensitive for GI hemorrhage. CT angiography can identify both the site and the cause of bleeding, providing valuable information for subsequent management. It is particularly useful in cases of active bleeding where the patient is hemodynamically stable, as in this case, right? So now you can see your theory is not correct, right? He's not unstable. The thing you need to understand is active ongoing bleeding present or not, right? So why not this air capsule endoscopy? Uh, is an excellent tool for investigate a small bowel can detect lesion missed by the other modalities. Right? However, it is most useful in cases of occult or intermittent bleeding rather than in active bleeding as this in case, right? The capsule take 8 to 12 hours to pass through the GI tract, making it less suitable for urgent situation. That is the reason we are not using capsule endoscopy. It will take time, right? 8 to 12 hours. So if we are waiting 8 to 12 hours in active bleeding, patient is done, right? So additionally, the presence of blood in the bowel can obscure view, potentially in limiting its diagnostic yield in active bleeding. In summary, CT angiography offers the best balance of speed, diagnostic accuracy, and the non-invasiveness for the patient with active GI bleeding of unknown origin. It can guide further management, whether that involve endoscopic intervention, angiographic embolization, or surgery, right? So I hope you get the point. So next question. 47-year-old all present to the because this part also not enough. You will understand why, because you need to catch these tiny points from emergency, as we don't have a proper surgical guidelines, right? Even for who are asking me like how to cover surgery, the my opinion, my preference is follow emergency, because that is the only source we have to follow. But some topics we have a proper guideline, but like some topics we don't actually have. Okay, now we'll go with this question, then you will understand the extra other point, right? 47-year-old man presented to the GP clinic with recurrent bouts of dark colored stool which have been occurred over last 12 months. The last episodes was 1 week ago. He reports fatigue and lethargy, and he has no significant medical history and take no regular medications. On examination, he appears well. Pulse rate is 97, BP 110 by 74, respiratory rate 16, SpO2 98, then the temperature 36.9. Endoscopy and colonoscopy have both been normal and each repeated on 2 occasions. His lab results are shown below. Hemoglobin 102, MCV 71 decreased, right? Hemoglobin also decreased. WBC 7.8 normal. Platelet 175 still normal. Which one of the following most appropriate next step in management? So in this case, what we should use is it CT angiography or capsule endoscopy? Mm-hmm. Okay, here. I know you all know the answer. The point is this. This patient history with bouts of dark colored stool, or we call it melena, and sorry, lab results showing the low MCV, most likely due to the iron deficiency anemia. Rises suspicious for upper GI bleeding. All hemodynamically stable patient with suspicious for upper GI bleeding require visual confirmation of the GI tract. So with the endoscopy, patient who have an inconclusive endoscopy are further evaluated with colonoscopy. Okay, here this is the important point. If both endoscopy and colonoscopy are inconclusive, both of these tests need to be repeated. If these results still negative, consider evaluation for this video capsule endoscope, right? This is because the standard endoscope and the colonoscope are unable to visualize the small intestine. The patient swallow a pill-shaped camera that display the inside of whole GI tract. So now tell me, what is the point you need to understand from here? Can anyone tell what is the point? What is the special point you have to take from here? Okay, just if one negative scenario is enough to go with capsule endoscopy, or do we need to repeat it again? Here, if both endoscopy or colonoscopy inconclusive, both should be repeated, right? So initially, if you are okay, you are done the endoscopy. First one is negative, then you are not directly going with capsule endoscopy. You have to repeat it again. The second one also negative, then only you have to go with capsule endoscopy, right? This is the point, doctor. If you understand the point what they are telling, if the both endoscopy and colonoscopy and conclusive, both should be repeated. If it's still negative, then only you have to consider about the capsule endoscopy. That is the point you need to take, right? Do you have any previously do you have noticed this point? This is the way of you should do in the proper way of understand the theory from these questions. Is it understandable? So when you should go with the capsule endoscopy, if the endoscopic or colonoscopic result are inconclusive after repeated endoscopic or colonoscopy result again still inconclusive, then you have to think about capsule endoscopy. That is the theory, right? I hope you understand. I don't think you have noticed this previously. Have you noticed this part previously? Or do you have any idea about this part? No, right? Yeah, that is the way of you should do because AMC is not a easy thing, right? They are changing the stems and they are very focused nowadays. Nowadays, but they are focusing more on these tiny details because they don't want us to pass the exam. They really want us to fail the exam, right? Because it's very competitive, and so many doctors are doing the MC exam and they are high up their standards, right? Like that, when you consider with this 2024 AMC exam and 2026, it's so much different. The thing is, they have asking so many tiny details, and they are always try to trick us. Like when we consider with like a very old AMC exam, it's like a totally very simple exam. Now it's very complicated. Yes, yes, doctor. Yeah. Okay, so what are the points you need to understand here? So this is the summary I can give. Same thing, okay? The capsule endoscopy indication is what? Both upper endoscopy and colonoscopy are inconclusive and repeated both tests still inconclusive. The next step is capsule endoscopy, provide the patient is hemodynamically stable, right? The capsule endoscopy is used to evaluate the small bowel which cannot be visualized with the standard GI gastroscopy or colonoscopy. It is the preferred investigation for suspected small bowel bleeding in cause of recurrent and occult GI loss, right? So CT angiography in hematoactive bleeding, right? Yes. Okay, remember these things. So in our case, the patient presented with melena for 2 days. The rectal examination was melena, colonoscopy and endoscopy were normal. Received 2 pack of blood. Next step. So I think because in at the moment there's an ongoing active bleeding. That is why the patient is received the 2 pack of blood. Right. This seems like the emergency first question. Right. In that case, what you can go with? You can go with CT angiography. So the thing is not the answer. You need to understand the theory behind it, right? Theory behind it. So that is how you should, because like anyone can think like that. Okay, patient is unstable. Go with the CT. No, that is not the theory, right? Patient should be having active bleeding, right? I hope this is understandable. This is a very important topic, and most of doctors have not noticed this part. That's why I chose this question. It's a very important one. No, doctor, if there's active bleeding, you have to treat it, right? You have to do the CT angio and you have to find the proper place. In that, you have to treat it, right? Yeah. So the next one, patient with sigmoid colon cancer, which one can guarantee 5 years survival? Okay, you are asking again indication for CT angiography. Patient should be a stable, hemodynamically stable patient with active ongoing bleeding with the past history of melena or like whatever, but on the moment, active bleeding is ongoing. Right? In that case, you have to go with CT angiography. Why you are not going with capsule? Just a simple theory, right? Okay, patient is having active bleeding. You are doing the capsule endoscopy. What is the point? It will take 8 to 12 hours to pass through the digestive system, and like after this GI bleeding, patient can be dead end of the capsule endoscopy, right? So like think logically, then it's easy, right? Yeah. Okay. So what do you think from this question? What is the answer for this question? Tell me the answer quickly, quickly. Okay. Mm-hmm. Okay. What else? What else? Tell me. Let's see what is your answer. Okay, what about other doctors? There are so many doctors. Yeah, this is from April. No, this is from February course, doctor. Yeah, this is from February call. Okay, I have chosen some topics from February and May. Okay. Okay, we got different here. Okay. Okay, what is survival mean? Okay, so survival, 5 year survival mean patient lives for at least 5 years after being diagnosed or after being treated the disease, right? Okay, after being treated the disease. Now tell me, okay, if there is a colon cancer, what is the best treatment? What is the treatment options? Option we have the best one. Tell me, doctors. So if we can resect the tumor, if we can remove the tumor, can we do it? Yes, we are doing the colectomy, right? That is the best thing we can do, right? Okay, if you have the best treatment and this sigmoid colon cancer is actually resectable, are we going with other therapies like radiotherapies, fluorouracil? Like, okay, if you have the main treatment in your one hand, you have other adjunct treatment like radiotherapy, fluorouracil, those things. So, like, if you have the main treatment and the other treatment in other hand, what do you choose? Okay, you are choosing the curative treatment or other treatment. Tell me. So curative always the curative treatment is what? It's always the colectomy, right? Colectomy, right, doctors? Yeah. So okay, we'll quickly discuss this one. Okay. So surgery recommend for many patient with colorectal cancer, and surgeon should have adequate qualification, expertise, especially those undertaking rectal surgery. Okay. So what about radiotherapy? It can be neoadjuvant radiation therapy recommended for with high risk rectal cancers. Radiation therapy may be given in the palliative intent of symptomatic non-resectable locally advanced colorectal cancer. Radiation therapy may be suitable for patients with colon cancer where the tumor has penetrated fixed structures, right? Mhm. So when we are using this systemic therapy may be beneficial for patients with a higher risk of relapses and who may benefit from the adjuvant therapies. Locally advanced high risk rectal cancers and non resectable cancers. So, palliative care, early referral to the palliative care can improve the quality of life and some case survival. So, okay. So, the time frame surgery conduct within 5 weeks of investigation. So, investigation and MDM if neoadjuvant, no need to just okay. Here they have given like when do you start the treatment and everything. Okay, so first of all, you have to evaluate the patient, right? If how long cancer is going, right? If it is a resectable tumor, you are not think about any other things. You need to resect it, right? You need to resect it. If it is locally advanced or invasive tumor, then you can think about other options like systemic therapy or radiation therapy, right? But first of all, you need to get an idea about what treatment you should choose, right? So in our question, what is here? Patient with sigmoid colon cancer. We don't know it is which type of cancer. Which one can guarantee? Which one can guarantee 5 year survival? If you have the proper treatment, the curative treatment, that is the best way to guarantee the survival, right? Right, doctors? Because like for giving radiotherapy, fluorouracil radio after colectomy. So okay. If you can do the colectomy, you can remove the tumor properly, right? So anyway, you can guarantee the survival. Okay, on only radiotherapy. Radiotherapy also can be given in different cases, but mostly given with the locally advanced disease, right? So it is not the curative case, right? It is not the curative case, right? Hi, doctors. So what about fluorouracil? Fluorouracil, why not that? It also for the advanced disease, right? It can be neoadjuvant, like just we just discussed. So my point is here, if you have the one hand, you have the curative therapy, and why you are thinking about other things, right? If you have the curative therapy, then you can do it. That is guarantee 5 years survival, right? Even more than 5 years survival can guarantee that. Because of that, the best answer is total colectomy, right? If you have the curative treatment, and why you waiting, why you keep this tumor with you like without resecting it, right? So if you resect it, you have the best outcomes, right? But I think they are not asking about advanced disease because they have not given anything, just a sigmoid colon cancer. So we can assume it's just a local cancer, and we can resect it. That can guarantee 5 years survival, like more than 5 years survival. Sorry, survival we can guarantee, right? Did you understand what my theory point? Because if we can't go with the colectomy, then only you can think about other treatment, right? Then only you can think about other treatment, right? So remember, one hand you have curative one, other hand you have other treatment. That who can't give this curative treatment, right? Curative treatment always has a great outweigh, right? Because of that, you should first think about curative. Can't only you can go with other treatment, right? So in that case, total colectomy is the best one that can reassure the patient's survival, right? I hope it's understandable, right? Okay. So go with total colectomy, but it can be different from what they ask because they have here, they have not mentioned anything. It's advanced, so it is metastasis or anything. They have not given. In that case, we can think about curative treatment, right? If they have given like locally advanced treatment, you have to think about other options as well as here they have mentioned, right? Systemic therapy, radiation therapy, because surgery is recommended many patients with colorectal cancers, right? Yes. Okay. Okay, then I have attached some extra things for February. Yeah, I think. Eight. Yeah, that is the question. Yeah, that is the question actually. Yeah, this is for extra knowledge because most of doctors have no idea because we have discussed this one in our other sessions. And okay, I'm going to ask a question. I have not attached this question. Okay. I'm going to ask a question. If there's a colorectal, wait, we'll do some question. Okay, we'll do this question, then we'll discuss. Okay, this is extra thing because this part also most doctors are like have no idea because I want to show the exact point from here. 65-year-old man present to the emergency department with this is something else. Okay, this is for the about treatment. Department with 5-day history of worsening abdominal pain, distension, and constipation. He has not passed stool or flatus for 3 days. He has a medical history and hypertension. Appendectomy 30 years ago. Take amlodipine for his blood pressure. So on examination, he appears unwell. His pulse rate is 110, BP 135 by 85. Respiratory rate is 22, SpO2 97, the room, 97, then 37.8 temperature. Abdomen is distended and tympanic with generalized tenderness but no guarding. Bowel sound are high pitched and tinkling. Digital rectal examination reveals the empty rectum with no mass. A CT scan of the abdomen is performed here. It's a CT scan. Okay. So now tell me which one of the following is most appropriate management. So type your answers in the chat, then we will discuss. Okay, then we will discuss, doctors. Tell me. because this is very much repeated question. This sigmoid colon cancer question. What about other doctors? Okay, in this one, okay, in here, what you can see? Is there anything can you see? Okay, I'll mark something. What you can see in A and what you can see in B. A and B. Tell me, doctors. A, type in the chat. A, what you can see, and B, what you can see. Have you noticed something in this point, the circled part, and here something dilated here in B, right? So what is dilated here? Is B narrowing? Is B narrowing or dilated? Can you see it's dilated, right? Okay. Here what you can see. Okay, what is this structure? This is structure is cecum, right? Okay, cecum is what is happened to cecum? It's a dilated, right? It's dilated. Can you see? It seems like you are very bad at CTs, right? Yeah, I should do a CT session because I asked. Okay, here, can you see what happened to this cecum? It's enlarged, right? It's enlarged, right? It's dilated, right? Distended. See, then what you can see in here? Can you see something here as well? Okay, I'll explain. First of all, we'll discuss what is going on with this patient. Yeah. The patient present with clinical features of large bowel obstruction which confirmed by CT scan showing obstructing lesion at the junction of sigmoid and descending colon. Right. So in this scenario, the most appropriate management is the immediate laparotomy and resection. Can you see? Everyone has marked the wrong answer. That is why I want to explain. Because most of the time, everyone was telling like if you see a sigmoid cancer and dilated cecum, go with stent only. That is most of the tutors or like other doctors are teaching, because that is not the theory. There is something you need to understand separately. Not every time we are going with the stent. That is the important point you need to understand. That's why I chose this topic. Okay, here why you need to go with immediate laparotomy resection without going with colonic stenting here. Why, doctors? Tell me. Why? Because you all are marked this colonic stenting thing. Have you noticed this question before? Have you noticed this question before, doctors? Do you know the theory behind it? No, right? Yeah, that's why it's very important. This patient present here immediate laparotomy and resection. The approach allows for the definitive treatment of the obstruction, removal of the likely malignant lesion, and prevention of the potential complications such as perforation or ischemia. The presence of abdominal tenderness can be worrying sign in such circumstances suggestive of ischemia. Okay, why not colic stent? Can be considered in selected cases only, right, of malignant large bowel obstruction, particularly in high risk patients, those with metastatic disease. However, in this case, with the otherwise healthy patient present with acute obstruction, immediate surgical intervention is the preferred treatment of option, right? Is it understandable? Don't worry, I will explain when to go with colonic stenting as well. Okay, here you can see the dilated, what dilated cecum, right? Dilated cecum and sigmoid stricture here or mass here, right? And this one also remember, CT scan is the image in modality of choice for diagnosing and staging of colorectal cancer, because this part has asked in the May exam. They are asking which imaging is the choice to diagnose and the stage in the colorectal cancer, that is CT. They have asked this one in May, right? These are tiny points they are repeating. That's why you have to give more attention to these emergency questions, right? Okay. Okay, so now I know now everyone is confusing. So why not stenting, right? Okay, so we'll do this question as well. Then you will understand. 72-year-old man admitted to the hospital with 3 months history of increase in constipation and 10 kilograms weight loss. Over the last 2 days, he has had absolute constipation and abdominal distension. His medical history include hypertension and COPD. Respiratory symptoms are such that he is unable to climb a flight of stairs. He takes peripheral long-acting bronchodilators. He's a reformed smoker with 40 packs years history and drinking 2 glasses wines at weekend. He appears unwell. Pulse 92, BP 135 by 85, respiratory rate is 20, SpO2 94. Temperature 36.8. Abdomen is grossly distended with thin clean bowel sound. A CT scan confirmed the stenosis tumor at the rectosigmoid junction with proximal distended of loop of colon. In addition, tumor deposits are visible in the omentum. There is some ascites and left hydronephrosis. Which one of the following most appropriate plan? Here they have taken it as a stent insertion. Now tell me why here stent insertion, and previous question why they have go with the definitive treatment. Now your chance to explain why. Yes. Did you understand the points? Okay, here. The patient presented malignant large bowel obstruction from metastatic colorectal cancer, the complicated by poor performance status and significant respiratory comorbidities. The management approach should be palliative, right? Minimize the procedural risk. So stent insertion is the most appropriate management option as it provides the effective palliation of the obstruction with minimal procedural risk, right? Colonic stent can be inserted under the sedation rather than general anesthesia, have technical success rate over 90% and allow the patient to return home quickly. They avoid morbidity associated with the surgery or trauma care. Right, yes. So, what about tumor resection and then colostomy? So, Hartmann procedure represent major surgery with a significant morbidity and morbidity risk, particularly given in these patients poor respiratory function with metastasis disease, such as extensive surgery is not justified for purely palliative purpose. Tumor resection also would be appropriate for potentially curative treatment in a fit patient with localized disease, right? Like in our previous case, right? Localized disease and the patient otherwise healthy. So, however, this patient has metastasis, right? Okay, here, colonic stent offer good palliation for poor surgical patient with malignant colonic obstruction. Surgical intervention carries a higher risk and morbidity in patient with advanced disease or poor performance status, right? Okay, here. So, these are the theory you need to understand. Here, if the sigmoid cancer presented with bowel obstruction, follow the following option, because these are very important. Metastasis disease, poor performance status, palliative intent, right? Best option is colonic stent, right? So, acute obstruction in otherwise stable patient, then you can go with curative intent possible, right? Immediate laparotomy and resection. Eye doctors. So these are the two things you need to understand. Like from okay, if you see this recall, okay, because there's a recall as well here. There's a recall. If you this is can't remember which one this recall. So if you see some kind of recall, these are the points you should gather from these recalls, right? Not just only okay, stand everywhere you see this is stand. Not the that is not the theory. You need to understand it very properly. No, no, doctor, this is my paid class group because I'm explaining from my paid recall revision classes. This is not available because you can see it's a very huge commitment. So I can't give it everything right for free because this is only for who actually need my help. Okay, I'm not, otherwise, you can just use other files and everything in my group. Okay, so there's other question as well. 83-year-old woman present to the emergency department by ambulance from home with a 2-day history of vomiting, colic abdominal pain, distension, and absolute constipation. This is on background of increase in constipation over the last 3 months. She has a medical history of congestive cardiac failure and COPD. Medication include metoprolol, ramipril, furosemide, and regular this ICS Lama Laba inhaler. She has a 40-pack-year smoking history. She reports becoming a shortness of breath after walking short distances. On examination, her abdomen distended and tympanic with high-pitched bowel sound. There is a tenderness of the left iliac fossa. Her rectum is empty, admitted to under surgical treatment. And CT scan show the stenosis lesion in the sigmoid colon and ascites. Which one of the following is appropriate management? So what? Why here we have go with the colonic stent? Now explain me again why colonic stent. Yes. So here what? Patient displays symptoms of signs and consistent with the large bowel obstruction based on her history of constipation as well as CT scan. So which demonstrate the stenosis lesion of in the sigmoid colon. The bowel obstruction is likely secondary to the neoplasm. So ideally patient with stenosis colorectal cancer would be offered a primary resection in situations like this, where the patient has acute bowel obstruction and emergency Hartmann procedure might be appropriate. In this case, however, the patient is not a good surgical candidate due to her comorbidities, right? The ascites is also suggestive of metastasis spread, the another factor that weight against surgical options. For these reasons, Hartmann procedures, transverse colostomy, defunctioning loop ileostomy are not the best options. Right here. So, given all factors and outline about the preferred method is what? The colonic stent. So, these are the indications: bridge to surgery, decompression for inoperable, unresectable diseases, palliative management, and management of unfit patient. Very important. Emergency has given all the theory for surgery, so you just have to go through. I know they have increase in questions day by day, like so many questions now. But what to do, right? You have to at least give impact, at least give priority for the surgery, right? Not only surgery, right? You need to actually follow these e-medicine. That's a very important thing. I'm telling again and again, if you don't have any theory or anything related, just go through e-medicine. You can find the theory and you can make your own notes, right? Okay, other topic is paracetamol poisoning. So, what do you know about paracetamol poisoning? So, this also came in February, I think March also they came in. Okay, I'll quickly explain. I think I have explained paracetamol poisoning like in different classes in our revision exam, yeah, high yield revision classes, but it's fine. I will go through quickly. Yeah. So, what do you know about the paracetamol? First of all, you need to know what are the types of paracetamol we are using, right? We are not always using the same paracetamol, right? We have different types. We have immediate release paracetamol, we have moderate modified release paracetamol, or we call it sustained release paracetamol, or we have syrup or liquid. So, what are the immediate release? Usually, it no, no, usual 500 milligram tablets, right? So the one that we are using in our day-to-day life, right? Usually 500 milligram tablets work quickly, used for common pain and fever. The modified release, often 665 milligram tablets, release slowly, used for the chronic pain, right? So syrup usually used in pediatric population. We are using it as milligrams per kilograms, right? Yeah. Okay, so most of the time, I have never seen they have asked from the this one modified release one. Usually they ask it from the immediate release paracetamol, right? So this is the treatment of choice for the immediate release paracetamol. Very important, okay? The time matters. Time matters. Okay, here. This is the chart you need to follow. This is in TG, and I also have shared in the group, I think. Can't remember, but if you need this one, I can share it again from TG. Okay, here. So this is the one you have to follow because the times matter. So what is the cutoff time? What is the cutoff time to decide the treatment? What is the cutoff time? Tell me, doctors. Very important. Tell me, tell me. Okay, what is the time? We decide there's a one time frame. It's a very important. What is that? 8 hours, right? Why everyone is silent? This is not a hard question. 8 hours, right? Ah, yeah, you have a doctor. I just saw the chat. 8 hours always matters because from 8 hours only we are deciding what to do, right? Okay, so if it is less than 8 hours, let's discuss. If it okay, why we are okay? First of all, tell me why we choose the 8 hours. What is the reason behind it? What is the reason behind it? Okay, doctor, after the session I will tell, okay? Because this is yes, liver toxicity. How liver toxicity? Usually this paracetamol take like a higher doses of paracetamol take at least 8 hours to do the liver damage, right? That is why we chose it as the 8 hours, right? 8 hours. So first of all, tell me okay, first of all, tell me what is the dose of paracetamol for the poison in dose? What is the poison in dose of paracetamol? It's in the emergency question. I'll show from the TG. What is the overdose level? Yes, okay, here. Okay, one doctor has asked how to double knot. You can't do it from the your telephone your phone. Just go here and just use the print option here. Then you can print it. Then you can save where you want to save it. Okay, here you can take this diagram, right? Here everything is very clearly you can see. If you want, I can just share it. This one, the group. Okay. So tell me what is the dose here? So toxic dose in acute paracetamol poison, the toxic dose is 10 grams or 200 milligrams per kilograms in patients under 50. You need to remember two of them or more. Patient who take more than 30 grams or 500 milligrams per kilograms in patient under 60 are increase the risk of acute liver injury. So 10 grams mean how many immediate release tablets? How many immediate release tablet? 10 gram mean how many immediate release tablets? Because they are not always given from the grams, they can give from the tablets count as well. So how many tablets include in 10 gram? One tablet is 500 milligram, right? How many tablets? 20 tablets. 20 tablets, right? Yeah. 20 tablets, very important. Sometimes they can give, the patient has ingested 25 tablets, then you have to understand, oh, it's more than 10 grams because 10 grams mean usually 20, that means 25 more than 10. Anyway, it's toxic, right? Yeah, remember like that. Okay, very important because AMC is not easy. Always remember AMC is very tricky, not easy, right? Yeah. Okay, so yeah. And this is the one we are using the nomogram, right? I know everyone has idea about the nomogram. Okay, I'll explain where I was here. Okay, so patient time since the ingestion less than 8 hours. Less than 8 hours mean still there's a no liver injury, right? Because after 8 hours, like it will take like more than 8 hours to do the liver injury. We can assume patient is still okay and If this patient less than 12 hours since ingestion up to 30 grams of paracetamol or up to 4 hours after ingestion 30 grams. Still we can offer active charcoal. So what does that mean? Okay, less than patient is less than 8 hours. 8 hours. Under 8 hours, you need to consider one more thing when to go with active charcoal, right? Active charcoal, you have two indication that is less than 2 hours and less than 4 hours. So how this time is depending on the amount of the ingested paracetamol. If it is less than 2 hours and patient ingest up to 30 grams of paracetamol. 30 gram up to 30 grams, that means less than 30 grams of paracetamol ingested, right? And the patient present in between within 4 hours and more than 30 grams of paracetamol has ingested, still you can give active charcoal. Very important, active charcoal. But I recently I have no seen this type of question like they offer in active charcoal. Most of the time they are asking to go with that next option. Okay. But remember, when to give active charcoals, we have two things, less than 2 hours and less than 4 hours. So less than 2 hours, up to 30 grams, right? Up to 30 grams. So if it is if it is more than 30 grams, you can give active charcoal up to 4 hours, right? That's a simple theory. Don't confuse. It's easy. Okay, next one. So anyway, even though you have offered active charcoal or not, the main very important part is the measure serum paracetamol level. This is the most important part. This is the mostly asked part. So it's a very important point. So you have to measure the serum paracetamol level and ALT concentration within 4 to 8 hours, right? 4 to 8 hours. Very important, very important, because sometimes they are not giving the active charcoal option. Anyway, they want to ask from this one, like, because the thing is, if it is more than 8 hours, sorry, if it is more than, not less than, more than 8 hours, you always start in from the neck. You always start in from the neck. That is why you have to differentiate these two things, right? Okay, so you have to measure the serum paracetamol level and ALT concentration within 4 to 8 hours of ingestion. Then serum paracetamol concentration, you have to measure it. Then you have to plot it in the nomogram. Then the nomogram serum paracetamol concentration below the treatment line. Okay, this is the nomogram. And wait, I'll show. There's a picture in here, right? In the TG. Okay, this is the nomogram, right? This is the nomogram. And this nomogram, we have the treatment line, right? We have the treatment line. Treatment line. If it is lower than the treatment line, lower than the treatment line, you don't need to give the NAC or the treatment. If it is more, if it is after, if it is above the nomogram treatment line, then you have to treat it. That is why we are plotting it, because still less than 8 hours. That means we can think about maybe there can be liver surgeries happening, sorry, liver injuries happening or not. That's why we are plotting it, right? We are plotting it. So here the serum paracetamol concentration below the treatment nomogram line. So below, that means you don't need to give the treatment. What you can do? No further treatment required. Advice. No further treatment required. You can advise patient return to the hospital if symptoms like nausea, vomiting, abdominal pain has developed. Right? Okay. Okay, you have plot. You have measured the serum paracetamol level and ALT concentration, and you have plotted in the nomogram. And the serum paracetamol concentration is above on or above the treatment line. That means you need to give the treatment, right? So I'll stop from here and start from here, then we will continue this part. Okay, then time since ingestion more than 8 hours to 24 hours. 8 to 24 hours. Just remember, more than 8 hours mean Anyway, you had started with the standard dose of acetylcysteine regime, right? You have to give the NAC, right? What dose? Standard dose, because there's a one indication you have to increase the dose as well. That is why this is the standard dose part is very important. Like you need to understand which dose you should give. So start the standard dose of acetylcysteine. You are not waiting. You are not initially do the paracetamol level check-in, no charcoal or nothing you are doing. If it is more than 8 hours, just give NAC first before doing anything. What NAC first before doing any other interventions, right? Because you need to save the liver first. Okay, then after giving the NAC, then you can measure the serum paracetamol and ALT concentration on arrival. When the serum paracetamol concentration on or above the treatment line of the nomogram, right? Or the ALT concentration equal or more than 50. If one of these indication present, then what you should do here also about the or know about the nomogram treatment line. Then you have to consider is the serum paracetamol concentration double the treatment nomogram line or higher? Okay, here the nomogram line is here and the paracetamol level is double or more higher, double or more higher from this line. You have to consider if it is present, if it is more higher or double the treatment nomogram line or higher, if it is yes, you have to increase the dose. The acetylcysteine, you have to give high dose acetylcysteine regime. If it is not, you can complete the started standard dose, right? You have to complete the standard dose of acetylcysteine regime, right? So let's remember. Then okay, you have patient after 8 hours and you have already given the standard dose. Then you have measured the paracetamol level and ALT, and this paracetamol level below the treatment line in nomogram. Then serum ALT also less than 50. Then you have to stop the acetyl infusion because there's no point of continuing it because it's below the treatment line, right? So here, and they have given another scenario, time since ingestion 24 hours or more or unknown. Here, unknown is the most important part. If you have no idea about the time, just give NAC. A standard dose of NAC, just give because you don't know. First thing first, you need to save the liver, right? 24 hours or more. Anyway, more than 8 hours or you don't know the time, just give the NAC. Just don't complicate it. Just remember from 8 hours. 8 hours. If it is less than 8 hours, what you have, you can consider active charcoal is possible or not. But otherwise, you need to always measure the serum paracetamol level. Paracetamol level. If it is like more than 8 hours, any case more than no unknown, more than 8 hours, so unknown case, just don't wait for it. Just start from the NAC, standard dose of NAC. Then you can do other interventions, right? Remember, very important. Okay, so you have given the standard dose of acetylcysteine, then you have to measure the paracetamol and ALT concentration. Again, the same thing. Serum paracetamol concentration lower than 10. Oh, sorry. Lower than 10 milligrams per liters or serum ALT concentration lower than 50. Stop it. Our paracetamol level is higher than 10 milligrams per liter or serum ALT concentration more than 50. Just you have to complete the standard dose of acetaminophen. So after anyway high dose or standard dose, what you should do? 2 hours before completing the 12-hour acetylcysteine regime, check the serum ALT concentration again. Serum paracetamol concentration. Then extended acetyl regime is required if the serum ALT concentration is higher than 50 or the ALT concentration has increased in patient who had baseline serum ALT concentration higher than 50, serum paracetamol concentration higher than 10. Right, but they are mainly asked from this one either go with measure paracetamol level or a start. That is the main thing, main point they are asking. Okay, this is from this one from the e-medicine question. This is very easier chart. Okay, easier chart. They have taken the 8 hours. If it is less than 8 hours, then measure serum paracetamol within 4 to 8 hours of ingestion. They have not mentioned about the active charcoal. If it is no, then you have to start with the acetylcysteine infusion, mesoserum ALD, paracetamol, serum paracetamol level, and the ALD, and you have to plot it in the paracetamol nomogram. Then after that, the same thing, doctor, they have given. I'll share if you want this one as well in the group. This is from emergency question, okay? So here, yes, we were discussing this part. Okay, we'll do this question, then you will get an idea. Yeah, I will share it. Twen- And doctors, please, I can't share all the information like updates and everything in both groups because uh, you're the one who requested me to make the AMC Victor's channel because of the doctors are sharing medicine links and like different messages. Then most of doctors can't see the my messages like the updates and classes and everything. Then I have made this AMC Victor's link. Then I'm posting everything there. Then again, doctors have just asked me, Doctor, today we have class and at what time, which class do we have, right? I can't answer everyone, right? Because I'm also a busy person, right? So because of that, please make sure to join the MC Victor's channel. Then only you can see my messages there, right? So you don't have any distractions, any medicine, nothing in there, just only my updates and whatever I'm sharing there, right? So because of that, please subscribe it. Okay, I'm not getting anything from you subscribing it, right? Just subscribe for your own sake because otherwise you miss the classes, right? Yeah, because you are the one who requested me to make that channel because of the so many email links in the group. I know because but I can't tell you don't share it because everyone need to get a free month, so those things. So yeah, it's I can't tell that don't share it. Which because but that's why I made that the MC Victor's channel, right? Okay, we'll do this question. A 24-year-old man brought to the emergency department by ambulance after ingesting 50 tablets of immediate release paracetamol, right? 50 tablets. Can you see they can give like this? So 50 tablets mean how many? How many grams they have ingested? How many grams? Tell me, doctors. Yes. And so how many grams? 25 milligrams. Sorry, 25 grams, right? Yes. 2,500 milligrams. Yeah, that means 25 grams, right? 2,500 milligrams, right? Because one tablet is anyway, it's more than 10, right? So anyway, you know the 20 tablets mean 10 milligram, right? Yeah, 20 tablets mean more, 20 tablets mean 10 grams. Anyway, it's up. Just remember because you don't have time to calculate it. Just remember if it is more than 20 tablets or more than 10 grams, then overdose. Okay, 50 mean anyway too high. So more than 20 tablets. So approximately 5 hours ago, according to the mother who phoned for ambulance after finding her daughter vomiting next to the empty medication packet. The daughter recently broke up with her boyfriend and has been experiencing troubles at work. She has no significant medical history. No, 20 tablets mean 10-gram, doctors, not milligram, 10 grams, okay? Don't confuse 10 grams. Okay, so they're asking. She has significant medical history and no regular medication. Her pulse rate is 75, blood pressure 120 by 70, respiratory rate 14, GCS 15, and no evidence of jaundice or astraxia. Weight 60. So 5 hours ago, 5 hours ago. So what you should do here, doctors? 5 hours ago, 5 hours ago, what you should do? Can we give active charcoal? Tell me, can we give active charcoal or not? I'm asking questions. Just yes or no. No, right? Because charcoal up to what? Charcoal up to 4 hours, right? Up to 2 hours or 4 hours. In this case, it is more than 30 tablets. Anyway, up to 4 hours we can give. Up to 4 hours we can give, right? Active charcoal, but patient is coming after 5 hours. So in that case, no active charcoal. Then what we can do? In the next step is 4 hours to 6 hours. What you can do? Urgent serum paracetamol level, right? Urgent serum paracetamol level. Let's see. The patient has ingested 500 milligram tablets of paracetamol, 50 of 500 milligram. So total ingestion is 25 grams. The toxic dose paracetamol that may be associated with the acute liver injury more than 200 milligrams per kilograms or more than or equal 10 grams, whichever this is lower. So, as such, any patient who ingested 10 gram or more is automatically considered to have been exposed to a toxic dose and is risk of acute liver injury. So the management of the paracetamol overdose is heavily protocolized through the toxicology guidelines and which relies on several key components. Dose taken, the formulation of the paracetamol, immediate versus modified release, time since ingestion and serum drug level. So here activated charcoal is anyway out. We have just discussed. In this case, the paracetamol injection, the main factor determined where the NAC before after checking the serum paracetamol is the time elapsed following the injection. So the same thing doctor they have mentioned here. Here usually we have to first check the serum paracetamol level because the time is less than 8 hours. It's between 4 to 8 hours. So you need to check the serum paracetamol level. Then if after that only we have to choose this patient needs serum paracetamol. This patient need NAC or not. If it is then after checking the serum paracetamol, we have to plot it in the nomogram. From nomogram, it is lower than treatment light. You don't need to give the NAC. If it is higher than or it is on the treatment light, you have to give it NAC, right? That's a simple theory. Okay, so for liquid paracetamol, we'll do this question. Okay. Because liquid paracetamol question also there in e-medicine. I have attached that one in my recall revision in February to because we don't know, right? Next time they can ask from this one as well as they are mentioned in the e-medicine. We'll discuss it from here. A 2-year-old boy weight 12 kilograms present to the ED with his parent. The parent report that 4 hours ago they accidentally gave him 45 milliliters of paracetamol syrup instead of the usual 15. This equates the 1080 milligram instead of the intended 360 milligram. They are worried about the overdose. He has no significant medical history and do not take a regular medication. On examination appears well within vital signs in normal limit. Pulse rate 110, blood pressure 90/60. Respiratory rate is 24 and SpO2 98 and the temperature 37.2. There are no signs of jaundice or hepatomegaly. Which one of the following is most appropriate next step in management? What do you think? What do you think, doctors? What do you know about the liquid paracetamol injection? Tell me. Please answer. Okay, just give it a try. This is not the exam, right? This is the discussion. We have we have more doctors, right? Mm-hmm. Okay, we have option C. What about other doctors? Okay, most of doctors are going with C. Let's see. Let's see you are correct or not. Check the paracetamol level and compare to the treatment nomogram at 4 hours post ingestion. So that is they are asking most appropriate next management. So why is that? The child has received an acute accidentally overdose of paracetamol 4 hours ago. The parent accidentally gave him 1080 milligram, which is 3 times intended dose. The recommended maximum daily dose is 60 milligrams per kilograms a day, but they have given 90, right? In this scenario, the most appropriate next step is check paracetamol level and compare to the treatment nomogram at 4 hours post ingestion. This approach is correct because we are we are dealing with the acute overdose that occurred 4 hours ago. The paracetamol treatment nomogram is designed for use in acute single overdose and is typically applied at 4 hours post ingestion. Right? Right, doctors? Okay, you have choose what? C, right? It's they have given 8 hours post ingestion, right? So for the liquid paracetamol, what is the time? You need to understand. Okay, here again 4 hours, right? 4 hour post ingestion. So okay, let's see this. Check-in paracetamol level at 8 hours post ingestion is not the best approach in this case. We have a known time of acute ingestion and can use 4 hour nomogram. The 8 hour rule is more applicable for situation where the time of ingestion is unknown. So the option, no need to read. So therefore, the most appropriate approach is checking the paracetamol level at 4 hour post ingestion and compare it to the treatment nomogram. This will guide a decision on whether administer acetylcysteine. Additionally, our liver function test should be checked and the child should be monitored for the signs of hepatotoxicity. The paracetamol treatment nomogram is usually assessed need for acetylcysteine in acute paracetamol overdose. In acute paracetamol overdose, the paracetamol level at 4 hour post ingestion is used to determine the need of acetylcysteine treatment. The recommended maximum dose of paracetamol in children 60 milligrams per kilograms per day or 15 milligrams per kilogram per dose, right? Maximum 4 doses in 24 hours. Right, doctors? So 15 milligram 4 doses or 60 like overall the 24 per day dose, right? So here this is the different. Why? Because this is the liquid paracetamol, right? Liquid paracetamol. So let's see about the liquid paracetamol. This is the one they have given in TG. Let's see. Yeah, here. Acetylcysteine therapy is not indicated if the serum paracetamol concentration is less than 100 when measured 2 hours after ingestion or less than 150. So when measured 4 hours after ingestion. So acetylcysteine therapies indicate the serum paracetamol concentration measured after 4 hours after ingestion is like 150 milligrams per liters or higher, right? So you need to understand what is the toxic dose and what's the time period we are using. Right. So here, if it is liquid paracetamol, we are taking that as the 4 hour as the window time, right? Right, doctors. So remember, they are not usually asking too much, but remember this question. This is the only one question we had in there, right? So yeah, doctors, this is the most important one they are asking, right? So let's go. I have attached some. Yeah, this that is for that is from few question from the February date 2 file, I think. Yeah, no, February, which file? Yeah, February day 4 file. And now I have attached some questions from May day 2 file. Okay. So how you should treat the rotavirus and what are the rotavirus? Because these kind of some new questions. Recently they have not asking from the rotavirus. Tell me how rotavirus present in pediatric population. Tell me, doctors. What do you know about rotavirus? What is the features? Is it a bloody diarrhea or it's a watery diarrhea? How it present? Tell me. What do you know about rotavirus? Mm-hmm. Yes. 1 minute. I'm getting a call. Just give me a moment. Sorry for that. Yeah. Okay, so I'll explain. So, what is a rotavirus? So, what are the points that you need to know? Okay, so common cause of viral gastroenteritis in infant and young children, right? A spread fecal oral symptoms, fever, vomiting, watery diarrhea, main risk dehydration, right? So diagnosis usually clinical, mild, moderate dehydration, oral dehydration we are using. This is like a simplest way. Severe dehydration, you have to give the IV fluids. No antibiotics, continue breastfeeding or feeding, prevention rotavirus vaccine in infancy. Okay, so previously they have given the rotavirus having after rotavirus the children can get the interception, but recently they have changed that point. Okay, changed that point. That means they have not interception is not associated with the rotavirus. That's the old theory, but now they have changed it now. Okay, so just forget that theory part, rotavirus and interception. Okay. Yes, yes. Yeah, yeah, doctor. Latest vaccine. Yeah, doesn't cause it, right? They have updated it in immunization guideline because previously we have to take it as associated with the interception, but now not. Okay. So remember. Okay, so yeah. Well, this is how it presents. So we'll discuss one question and we'll discuss about the treatment after that. 3-year-old girl presented the GP clinic with 2-day history of profuse watery diarrhea and vomiting. Her mother reported that she has 8 to 10 large volume water stool per day without blood or mucus. Diarrhea has continuous despite the withholding food for the past 12 hours. She attended child care where several other children have been unwell with the similar symptoms. She has no significant medical history, does not take irregular medications. Immunizations are up to date. On examination, she appears mildly dehydrated with dry mucous membrane. Her pulse rate is 120. Blood pressure 90/60, respiratory rate 24, SpO2 98, temperature 38.2. Her abdomen is soft with increased bowel sound and no tenderness or masses. Which one of the following organism is the most likely to cause this diarrhea? So, what do you think? I know you all know the answer, right? So, it's a rotavirus. Why? The child present with acute GI, acute gastroenteritis characteristic by profuse watery diarrhea that persisted despite the fasting, consistent with this secretory diarrhea. The presence of similar cases in her child care center suggests it infectious outbreak. The child under 5 years, rotavirus is the most common cause of severe diarrhea worldwide and typically present with this clinical presentation, right? So here the characteristic features include profuse watery diarrhea, vomiting and fever with symptoms typically lasting 3 to 8 days, right? Okay, here how you should treat. Okay, the main complication is what? The main complication is what, doctor? The dehydration. So you have to treat according to the dehydration level. So first of all, you have to assess the severity of the dehydration. If it is mild, moderate, or severe. So if it is mild, what you can do? Mild, how it present, alert and responsive, like almost everything is normal, right? Almost everything is normal. In mild dehydration, if it is a moderate one, so patient is lethargic, normal or mild tachycardia, increased respiratory rate, and the extremities are warm, eyes and fontanelles are sunken, mucous membranes are dry, skin tag is mildly decreased, and the capillary fill is prolonged, right? So if it is severe dehydration, the child is reduced conscious level and the tachycardic, increased respiratory rate, deep acidotic breath, hypertension present, pale or mottled skin, cold extremities. Here then a weak peripheral pulse, right? Deeply sunken eyes and fontanella. Mucous membranes are very dry. Skin turgor decrease and the capillary fill is markedly prolonged, right? So how you should treat? For children with mild or moderate dehydration, enteral, oral, or NG rehydration is preferable. So, IV fluid rehydration is required in severe dehydration or children who cannot tolerate enteral rehydration. Okay, so this is the approach. Does a child require urgent fluid resuscitation? That means if the child is hypertensive, rapidly deteriorating, right? In that case, you have to think about patient need urgent resuscitation. If it is years, you have to give 10 to 12 milliliters per kilograms bolus of sodium chloride 0.9, right? So as a bolus. So if it is not no need urgent resuscitation, then you have to understand, can this child fluid need to be met enterally or not? If it is yes, you can give oral or NG or PG fluid, right? So if it is not, need to be met enterally. If it is no, then you have to check blood glucose, clinical assessment of hydration status, and current weight, pre-morbid weight, and intake, output chart, and electrolytes. Everything you have to check. Then you have to choose the most appropriate fluid type. That means sodium chloride 0.9 plus glucose 5% with or without KCl. Then you have to calculate appropriate fluid rate, consider maintenance fluid rate, need for the fluid restriction, example like 2 to 3, maintenance, majority of unwell children need for replacement of fluid. Then you have to consider after starting IV fluid, reassess the check of clinically and review the fluid order within 6 hours. So this is the way you have to choose. But yeah, is it understandable, right, doctors? Yes, very important because they have not given like a proper one. Just you have to follow the dehydration pathway they have given in RCH guideline. Okay, it's already 5, right? Okay, I'll explain one more question. This is also a new thing because most of doctors have no idea about this one. So let's discuss. 17-year-old girl, 11 week pregnant, had issues with family and the left home, has boyfriend but live on the street. Child support advice to go back to home, inform the family. So what do you think? What you should choose? Tell me your opinion, doctors. Tell me your opinion because most of doctors have no idea about how to approach this kind of question. What do you think? Okay. What about other doctors? Quickly answer. Okay, why child support? Why child support? Okay, as a child is 17, right? Okay, so child is 17 and without, I'm asking, without her consent or without asking her, can we just recommended, can we just counsel for the child, okay, recommended for the child supportive agents or anything? Can we? Okay, how you should assess this kind of children? Because it's still children, right? 17, less than 18, right? Less than 18, right, doctors? The patient is less than 18 and he's a 17, right? 17 and she has their own capacity to take her decisions, right? So, okay, first of all, how you should assess this patient. In adolescent care, especially for a 13-year-old, the doctor should first build the rapport, right? Then assess safety and the capacity, then discuss the support option with the patient. Because she's not a small child, right? You need to explain it first. Okay, this is from the RCH guideline. They have very explained. We have given a good example for the adults. For the adolescent, okay, here. There's a something called this one. He does psychological interview. I don't know how am I pronouncing it correctly. Or he does or something like that. There's a psychological intervention for adolescent, right? So our child also adolescent, right? 17. So how you should assess a child in this age. So you have to follow this one, right? So we have to build the rapport first, right? Then identify risk and protective factors, the young person's competencies in order to look for opportunity to intervene earlier. Then identify healthy and maladaptive coping strategies and support system. Like who can okay, as example, okay, this child is pregnant, and she's left the home, right, left the home, and now living in the streets, right? First of all, what you have to think, you have to talk with this patient, and you have to make a secure area, like a secure area to patient to be comfortable with you, right? Or patient to open up with you. You need to make a comfortable space for the patient. That is the first thing you need to do. You have to build the rapport, because the anyway the he's a teenager, right? He has own capacity. Then, like, you have to make the very good space for this girl to open up with you. Then you have to make sure that everything is between the doctor and the patient only. The confidentiality also safe with the doctor. You have to make sure that, like here, these are the example. I'm going to ask you all about your life, and some questions will be personal. Whatever you say will be kept it private and between us, and not be passed on your parents or anybody else outside the room unless you give permission, right? You have to make sure to this child is open up with you, and you have to make sure the confidence is safe with you, right? Right, doctors? Okay. So this is how you should build the rapport, and you should make sure the confidentiality and everything. Okay, first thing that is right. Then you have this one. This here as psychosocial interview. So here H mean first one home, where, with whom, recent changes, moves, so new people, relationship at home, with family stress. Then you can assess this one according to these the screening tool, right? Like in under home, our patient can assess, because patient is already left home. Like there can be some violence in the home, like or neglect, whatever, right? You have to first make a safe space to patient to speak up, right? Okay, here. So first build the rapport as a safety and the capacity, and discuss support options with the patient, because she is a 17-year-old girl. If she is having the capacity to understand everything, then the only thing you can do is you can give some suggestions, like is there some teenager support teams, is there any child support agencies, like you can give suggestions, right, to this child. Like you can directly recommend this child to these support services. You can't do that. First of all, you have to explain the options that she has, right? Then only if she's okay with that, here discuss support option with the patient. You would usually ask if she's comfortable involved in social workers, youth support service, family or partner support, right? Then you have to confidentially should be respect unless there is immediate danger, abuse, or significant risk of harm or mandatory reporting. If it's, you have to understand is the one of some mandatory reporting present or not. If it is not, like as a abuse or anything is not present, then you have to follow the normal pathway. Like normal, first assess the competence, make the safe space to patient to open up. Then you can suggest the options you have. In that case, you have social workers, you support service. Then you can suggest these things. Then you can ask this patient, like, are you comfortable with these services? If you are okay, or if you can give the permission for me, then I can suggest you these supportive service. I can arrange some arrangement with these social workers or child support services, but only if the patient is comfortable with that. If patient says no, I don't want, then you have to respect her, right? Because she's a 17-year, she has the competence, and you have to respect her autonomy, right? That is the way of treating. Like you can't directly go to the child support. I don't know what are the other two options. Other two options can be check her competency, right? Check first, the other options can be assess her capacity, right? If it is those kind of options is present, you have to go with that, right? Because advice go to back home not appropriate, inform the family not appropriate, child support can be a safe option, but only if she okay with that. Otherwise, first thing first, you have to make a space to open up for her. Then you have to secure the confidentiality, and you have to give the options. If she okay, and you have to assess it first, her capacity and everything, then she's okay with that, you can give the support. This is the way you have to think. Otherwise, if you okay, everyone marking the child support okay. If you see this question in the exam, this is the last May exam recall. If you see this one and you see the child support okay, yesterday we have done our child support is the answer. You are not even thinking about assessor capacity or assessor competency. You are not even think about those things. You just mark and go. Answer is wrong, right? So answer is not any of this, doctor. Child support if she's only okay with that. Answer should be, because only three options here, right? These are the records, right? Don't ask me what is the answer. Answer, we don't know what are the other two options, but most probably it can be assessor capacity first, right? Assessor capacity, because she's a teenager with a pregnant woman, right? Pregnant woman. Yeah. Maybe you have to assess. So you can do this. He does a screening tool. He also like covering everything, right? Anyway, first you have to assess the patient. You have to counsel the patient. Then only you have to give the options if patient is having the full mental capacity, right? Yeah. Best thing first. First thing first, you have to assess the patient, right? Yeah, that is how you should approach, right? Here, assess with this, he does ensure safety, explore the support system. Then you can offer referral or social child support with their involvement when it possible, right? But patient need to give the permission for that. Otherwise, if she was like, no, I don't want any support from anyone or anything, just you have to respect her autonomy, right? Right, doctors? I hope it's understandable. That is the way of approaching this kind of question. Because don't remember the answer, everyone marking child support. Oh, this is the answer. No, that is not the answer. Because in the exam, you will get the full stem. You will get the full stem, and or there can be more options. Here, only three options. Other two options can be the better option. We don't know, right? Yeah, like that. That is the way of doing recalls, right? Okay, so I'll explain this one as well. Because I have my the proper recall revision class after this. Yeah, okay, it's fine. I'll explain this one and stop it. Anyway, it's already, we are close to 2 hours, right? So there was a question about effectiveness of two drugs. Both were under the therapeutic curve. Ask which one is more effective. So what do you know about this under therapeutic curve? What is that stat question? Does anyone have the idea about it? What do you think? Okay, they are given the two drugs, two drugs in this curve. This is kind of this kind of the graph they can give. Okay, so what is it? They are giving the two drugs, drugs A and drugs B, and they are giving the this chart. So y-axis mention the plasma drug concentration and the x-axis mention the time. So they are giving how these drugs are acting, like their concentration, how varying with the time, right? 1 minute. How varying with the time, right, doctors? Okay, how? So when consider with that, so drug A, here you can see the drug A and drug B, and here they have given the therapeutic range of the drug, right? Therapeutic range of the drug, and this therapeutic range has the upper limit and the lower limit. Okay, what you can see in this drug A? Drug A, what you can see, doctors? So drug A, okay, you have given the drug A, and this patient is having higher peak and short duration, higher peak and short duration. So rapid absorption. So rapid absorption can occur. Then what happens? Short duration in therapeutic range. Can you see? He's in therapeutic range only till here, right? So usually 7 hours, right? 7 hours only. Okay, so what about drug B? The slow absorption, right? The slow absorption and lower peak concentration, but prolonged duration in the therapeutic range. So, how long? From here to here. Like, how long? The drug B in 15 hours in the therapeutic range. Can you see in therapeutic range? 15 hours. This drug A is only in the 7 hours, right? So, what is better? What is better? Like overall, drug exposure is better in which drug? The drug B, right? Drug B. So the what are the main thing you can get in here, like main idea? The drug with the larger area under the curve is more effective, right? Because better overall exposure when its peak concentration is low, right here. Because this go up and down. That's it only, right? Yeah, so B is more effective, right? Yeah, so what is the theory you need to understand? Bigger AUC is a more effective, right? More overall drug exposure, better in clinical effect, right? Okay, so what is it? So what is this area under the curve? What does that mean? Under the curve mean the area below the drug concentration time graph. It represents the total amount of drug exposure in the body over the time. On the graph, we just discussed x-axis in the time. Y is drug concentration in the blood. So shade area under the line or curve, we call it area under the curve. So bigger area, drugs stay longer or more drug absorb. Small area, less overall drug exposure, right? So large AUC more effective overall, small AUC less exposure effect. Like they can give this kind of scenario, and you need to understand in therapeutic range how long drug can be staying, right? According to that only you have to decide, right? Yeah, drug B is the one therapeutic range for much longer time. And so since the drug B has the area under the curve, it's more effective overall. More effective overall. Okay. So I hope you understand it. Yeah. Yeah, doctor. So these are the questions that I wanted to explain today. How is today's sessions? Is everything understandable? Because this is the recall we got. Because the recall we got, we don't know anything. And this is my explanation, all the diagrams and everything. Okay. Yeah. So do you like theory classes? So these kind of question classes, because anyway, I'm covering theory as well from here. This is the way of typical my recall revisions. Yeah. So what do you prefer? Tomorrow you need this kind of session, or what do you prefer? You need some our theory sessions. Both are good. Okay, I can do one day the question sessions and one day theory session, right? Okay, both. Okay, because last week and this coming week also I will be like quite busy because you all know the jobs and everything. It's a quite tired for me as well. That's why last week also I couldn't do the sessions, but this week I can manage the time and everything. Okay, I will do these kind of sessions. And please, doctors, subscribe that AMC Victor's channel because I don't have time to reply all the messages. Like it's a small, like a kind request because then otherwise I feel so bad if I can't reply everyone. And one more thing, like I will do a session like how to prepare again because I'm getting so much messages. Like I'm a medical student, I'm a postgraduate doctor, and I don't know so many messages like how to prepare. Some are just directly asking some doctors, please give me a study plan. I don't know why they are acting like this because I am just doing some classes only, right? I can't decide what is prefer for you, but I can help. Like I can give my opinion, right? Because please don't ask me like just in the random messages. They ask me, please. I'm in this one, and I have done this much of e-medicine. So what I can do next? So yeah, I don't have time for that, right, doctors? Because to reply everyone and what. what is the next thing, like you should decide, because in the beginning, in our first video in my YouTube channel, I have explained each and everything stepwise, how to pass this exam, right, from my experience, right, how long you should do the recalls and how to do it, how to do the emergency questions and everything. And I have given so many videos. First you should watch them, right, watch them and get an idea, not directly ask it. 300 in it. Okay, so I will arrange a, because I will arrange a small session for like to get to give an idea, because when I was preparing, I have observed like how these questions are coming, because in the exam we have easy questions, we have moderate level questions, and we have like a harder question. That is these three questions we are getting. For the simple questions, like not very harder questions, easy questions, you are getting a low mark. Moderate questions, you are getting a moderate mark, and the higher, like a harder question, you will get a higher mark. So I will explain the how it going, like from a stat way. Then you can just target the moderate, like how many moderate questions you should do to get to pass the exam, to cover the 250, to target the 250, right, the level. So I will give explanation, but it's not the like a proper way. That's like an idea, because I have done like many, not a research, I was spending time to like get an idea like how it happened before my exam. Okay, not recently, before my exam. Like how these marks are going, how to pass this exam, doing the moderate questions, not doing easy questions, like how to keep these level in a moderate level, like that. Because if you are doing when you are doing exam, if you get a, first they are starting from the moderate level questions. If you have done some mistakes, then they are chosen like a less harder question, right? Okay, you are doing the moderate harder time question, then you have got the wrong answer, then they will give the, they will reduce the harder level little bit than that moderate level, and they give the question. Then again they are checking, no, you are able to mark this correct or not. If it is still again you are not marking it correct, then that is how they are reducing their the level of the hard, like it's a harder question or not. But if you are reducing the level of the standard of the question, like an easy question, mean you can't get the proper score, right? Because the easy questions are not getting the much more marks. That's why most of doctors after exam they are telling, okay, exam was quite easy, I got a good questions, and like I felt like everything went well, but still can't reach 250. The thing is, if you are doing the easy questions, mean the failing possibility is high, because the thing is easy questions mean less marks, because even though you are doing a like a good amount of easy question, you are not getting enough marks, right? So always you should do the harder question. Or okay, can you see in March exam questions were very harder, right? It's a simple explanation. Okay, March exam questions were very hard question. Like you have to think so much, and you like sometimes feel like the mind blowing question, right? But those question has like a higher score, higher mark, right? Even though you have able to the mark correct answer for those questions, you will get a higher mark. Then like a less amount of question is enough you to pass this exam. An April exam, most of the questions were like easy questions, right? Easy questions and like approachable questions. But the thing is, like easy means they are not giving the proper marks, right? Proper score, right? Even like if you're getting harder question in the exam, that's the best thing, because then you can score more, right? It's a computer adaptive test, right? So it's better you need to get an idea, right? Get an idea, and that is how you should yeah, you should mainly focus, because I will explain from my experience and everything. Pray for harder question. No, don't pray for harder question. Pray for moderate level question. Moderate level question. Then you will have better chance to pass, because harder question is it's a hard always, right? It's so like it's hard to get the proper answer. But if you are like very good in knowledge and everything. Your luck also like 200%. You can do it, right? Yeah. Yeah. Better to try to keep your questions in a moderate level. Because if you are going down, that means even though you are doing more correct questions, you are not getting enough marks, right, to pass. Even I know in most of doctors in April exam, they failed by just 1 mark, just 2 marks. The range is mostly from 240 to 250. It's a very sad thing, and I know I felt so sorry about the doctors who have done the April exam and got the marks between 200, mostly not 200, actually 245 to 249. Yeah, I know. And I know some doctors. Okay, then I have to tell another thing that I have noticed in April exam. Previously, to pass this AMC exam, to pass this AMC exam, you all know that we have different categories, right? Surgery and the medicine. If you need to pass the exam, pass the AMC exam, you must pass these two. Like they are giving like a scope, like there's a line. This one is green side, and the middle one is like orange side. The other side is a red side. That means fair side. To pass the AMC, the surgery and medicine always should be in green side. Okay, always should be in green side in previously, but in April exam, I have seen there are two doctors in they have shared with me because they were in my paid recall sessions, and those two doctors has passed one from 251, one from 251, other one from 253. And then I asked the chart, this scorecard, and what I have noticed, one doctor has actually failed medicine, but not in failed medicine, but it's in the border level here, border. Okay, because this is the satisfactory side, that means passing side. This is unsatisfactory side. This is the middle one. This is like a middle, from unsatisfactory to satisfactory. Her level is in this border, but cross in the fail side. Okay, but she got passed with 251. I think 51 or 50. I can't remember. And there's a other one who passed from this 53 or 51. Like two doctors I have only noticed. Okay. Other doctor has score like around this 250 around. But the thing is, failed surgery, and it also like in this area. So that is a, I don't know how to take, it's a good news or bad news, but kind of feel good news because previously the both surgery and medicine must be in this side, the green side, the satisfactory side to pass this exam. Not for like ups and genes. Others can be in red side. Do we need to? No, doctor, because in September exam, there's one doctor who's my very good friend, okay, very close friend. He scored 280. He scored 280. You know his scorecard. Like everything is in the green side. Okay, everything is in green side. A very good score, but he failed pediatrics. He failed pediatrics. Pediatrics also in this area. Okay, this area like this, but not in more red side. Just in the light. That means failed anyway, but score 280. But his surgery and medicine level is in a very good, like in here of the green side. But there's another doctor I know who failed gyn and ops, but got 260 something and fast. But those all the doctors has surgery and medicine in a green side and a good level, because that is the only result I have noticed in only in April. The two doctors, one failed medicine and surgery, but they have passed from like a margin level, 251 and 253. It's a margin level. I think because that is the reason, because they failed this one. I feel like they have to pass this AMC. You don't You don't need to like pass all the, you don't need to pass the all medicine and surgery, but I can't tell because I only saw two scorecards of like that. So it's fail or pass if we fail in one subject. So previously, I was telling previously, even though if surgery and medicine you are in pass level, like you have failed even pedia or genanops, like still you can pass the exam. That is, but you have to pass surgery and medicine. That is the standard they had. But recently in April, I have noticed this too. That mean, but if the scorecard is like other things in the red side, like a two subjects, if you fail, you never can't. But in previously, just one subject from, but not from surgery medicine, from pedia or gyn and obs. I have seen only gyn and obs and pedia, like mainly from my eyes, the scorecard. They have passed the exam with a good score. But in April, I have seen one doctor has failed medicine and other doctor has failed surgery, but other subject all line green side. Okay, other subject all line green side pass from this marginal level 251 and 253. Yeah, so we can't predict AMC, right? We can't predict because previously we know both should be passed, but now we can't tell because the here I saw two scorecards still got passed, still got managed from 251 and 253 because of the, even though surgery or medicine fail, right? So this is a analysis because I can't completely tell anyway. Don't think like this. Just try to pass each subject because you don't need to take some risk, right? Because of that, please do it. Otherwise, like I don't think the AMC. We don't know the pattern now because it's kind of confusing. Because previously something else. Now I have seen in April exam two doctors like this. And overall, the April these two result is a good thing because even though they have failed medicine and surgery, still managed to pass the exam, right? Like that. Like if you have like failed the exam in previous attempts, so you have to take your scorecard and try to do more in the fail part. As an example, if you failed surgery, more focus on surgery. That doesn't mean like you don't cover the other things, okay? More focus because that is your weak area, right? And please, if you have failed the exam, don't think, okay, don't be over stressed because that is the exam, okay, not your life. Because AMC, no one is able to pass in the first attempt because AMC is not only your knowledge. Like if you fail, mean it's not depend on your knowledge because AMC is always depend on your the mental situation, right? One, how you are doing the exam at the moment, how your mind is working. If you get anxious or if you get stressed, you can't pass. Right, and the other things like the luck also like very important to pass the AMC. Even though I know some doctors who have worked very hard, I know personally very hard, but got failed. The thing is, they got stressed, right? You have to be more confident and calm once you are doing the exam, okay? So these are the things I have explained multiple times in my YouTube channel, YouTube videos also. So keep these things in mind. And I really want to tell you, I saw one doctor has mentioned like 248 and like don't think this is a failure. Doctor think everything's happened for a reason, okay? Everything's happened for a reason. Something because you need to do it next time. We don't know, like you can be like more than 300, right? You will be getting a colorful mark, right? So we don't know the what is the plan for our next thing. Because of that, don't be too hard on yourself and you need to focus. Just forget what happened to, but you have to understand the mistakes. Like it can be your mistakes with the less amount of emergency questions. The mistake can be you have not done enough recalls, right? The mistake can be exam anxiety, right? So you have to write down your mistakes only and just forget you have done one time and prepare it again as a new attempt in the first time, right? Just forget, Like why you always try to live in your past, right? If it is failed, just fail and forget, but you never forget the mistakes you have done in earlier attempt, right? Write down your mistakes and try to overcome one by one. Okay, I will explain how to like mind how your mind should be planned after this kind of situation. Okay, then I will explain. I will make a small session like how this scoring system and everything is going on. I think it will be very helpful for June doctors as well, right? So this is a very doable exam, doctor. You need to be like more focusing on these things. Okay, then you can pass this exam, right? Okay, doctors. It's already 2 hours because I have my other class in at 6, this recall class. We are discussing the May recall revision like this. So, yeah, we will meet tomorrow, doctor. Yeah, tomorrow at the same time, I think we can meet. Okay, thank you so much, doctors, for joining. Yeah, Mr. Recalls. Focusing on emergency. If you already done the theory, yeah, that's enough, doctors, because I know the please listen the March exam result. There's a one doctor called Sachini Utpala. uh, that is the best example I can give overall. She's the best example I can give. The thing is, she has done her exam in 2024. I think 2000. Look, anyways, 1 year earlier. Then she got failed like from 2 marks or something. Then she has just forget AMC, and she was doing her work in Australia as a health aged care manager, and she has not touched anything clinically for 1 year. Then after she called me, and then she only joined my recall revision classes, and she started from the uh, November recalls, and she continuously works. She has a work from morning. She start her day from morning 5 to then I think night 7 p.m. She has to work schedule, and she has a small baby in her, not a baby. A small boy, and she has to manage a job and everything, but she continuously listen the recordings and everything, and not even any theory, just only the recalls class videos. But she has worked so hard even in her every time, like leisure time. Sometimes she was telling, I was listening the classes, sometimes the same we recording for 10 times. That much she has worked hard even doing her the work life balancing and everything. But she, March exam, she got 268 or 70 or something, 260 something. I can't remember. And she passed the harder exam. Okay, not a easy exam, one of harder exam. That is a better motivation. She just only did the recalls, e-medicine only, and she managed to pass. Okay, after 1 year, she come to do the AMC without even having any knowledge, without any practices, because she's not doing anything related to our field in Australia for 1 year. That is the best example you can think. If she can, and she's a mom herself, if she can do that, you also definitely can do that. Okay, please listen her story, then you will be very motivated. Even I am so proud of her still, because she is like a warrior. She has managed everything. Just only did the recalls. Yeah. Okay, doctors, that is enough for today, right? I will meet tomorrow. Have a good day, doctors. See you.